Welcome and good afternoon today. Thank you for joining us on our ongoing series, and for today's presentation, Trust Your Gut. What do you need to know about your digestive system? Presented by Dr. Batista and Dr. Strobel of our gastroenterology and hepatology department at Mayo Clinic Health System in Southwest Wisconsin. Next slide, please. My name is Dr. Paul Moling, Chair of Primary Care in Southwest Wisconsin, and I'll be your host for today's program. I would like to introduce our speakers. Next slide. We have Dr. Batista, Chair of our gastroenterology department here in Southwest Wisconsin, followed by Dr. Strobel, who is an advanced endoscopist offering those procedures here locally. At this time, I'll introduce Dr. Batista. Please take over.
Thank you so much, everyone, for joining us this afternoon on this first series on digestive health. There's so much to talk about in GI and so many questions that often come up that we selected a few of the topics that we see in clinic most often. And so what we're hoping to accomplish today is to introduce some of the common problems and symptoms that should prompt you to seek medical attention, highlight the importance of screening tests for common GI conditions, and also to help you gain a better understanding of digestive health. We'll kind of start from top to bottom and cover some of these common symptoms and complaints that we see to share some information with you. The first thing we'll talk about is dysphagia. And dysphagia is basically the medical term that we use to describe difficulty swallowing, that sensation of food getting stuck. Sometimes we see this in the emergency department when it's quite dramatic and patients are eating something, a piece of chicken or rib, and it gets stuck and they are very uncomfortable and they can even swallow a sip of water or their own secretions. This is a very dramatic presentation of dysphagia, but there's also much more common presentations of dysphagia, which over time people start noticing that certain things don't seem to go down easily. And it usually starts with solids and then liquids as it progresses with time. There's many causes of dysphagia, and some of them I have highlighted here that are more common. First will be esophageal dysmotility, and this just refers to the inappropriate functioning of the two muscle layers of the esophagus. The esophagus, like many other parts of our body, works in a very coordinated way in order to allow us to swallow something that we ingested. So sometimes there's problems with the contractility, with how strong the muscles or the nerves in the esophagus work, and sometimes there's problems with a lack of relaxation of those muscles. And we can certainly do the investigation for that and try to get some answers for the patient. Another condition that can lead to difficulty swallowing is eosinophilic esophagitis. This is an autoimmune condition in which there is an inflammatory response to certain foods or allergens in the environment that leads to scarring and fibrosis of the esophagus, which makes it stiff and unable to relax and to accommodate a food bolus. Peptic strictures is a common cause of dysphagia, and this just refers to scarring and fibrosis of the esophagus and narrowing of the esophagus as a result of uncontrolled reflux over the years. And then the more serious cause of dysphagia will be esophageal cancer, and basically having a tumor or a growth in the esophagus that starts occupying space and eventually can lead to a full obstruction and inability to swallow. The evaluation for dysphagia usually would include some radiographic testing to assess the swallow function, an upper endoscopy to rule out any structural lesions or narrowings in the esophagus, and possibly a test called esophageal manometry, which is a catheter through the nose that is able to measure the muscle contractility, relaxation, and nerve function of the esophagus. The treatment obviously would depend on what the results of that evaluation would be. And as you can see, it's something that requires the integration of multiple specialties to get to the bottom of it.
All right, thanks for having and joining us here. I want to talk about reflux. So reflux is a very common disease, and there are some different terms that are important. So reflux or acid reflux is when acid flows from the stomach in our food pipe, which is normal if it doesn't happen too often. That's just how the body is made. What we call GERD, or gastroesophageal reflux disease, is if you have heartburn more than 2 or more times per week. And that is kind of not normal anymore. And that I would recommend to talk to your primary doctor or to us to kind of see if we can help you with that. So with our diet and lifestyle, GERD is pretty common nowadays. And if it's only mild or mild acid reflux, you can just do some lifestyle changes, weight loss, small meals, don't eat just before you go to bed. I mean, no one has anything against having reflux after Thanksgiving. That's kind of normal. But if it's more than that, you should kind of seek attention, especially if you have what Dr. Batista described earlier, any warning signs that you can't swallow anymore, that food gets stuck, or that you're losing weight. Those are all things that would need further evaluation. And some conditions can be fixed surgically, and that's what we offer here at Mayo Clinic. So some conditions can be treated and you don't even need medication anymore. Next slide, please. Another common thing we see is called Barrett's esophagus. And that's kind of a consequence of having acid flowing into your food pipe for a long time. We're talking about years. And there are different types. So the stomach is kind of a corrosive tank that kind of made to hold the acid, versus the food pipe is kind of the lining of our mouth. And if the food pipe gets exposed to acid for years, it kind of changes to the lining of the stomach, to the corrosive tank lining, which is kind of smart from the body, but it carries some risk. And one of the risks is that you can at higher risk for developing cancer of the swallowing tube. So there's some risk factors that you should keep in mind and discuss with your primary or with us. Like if you have GERD symptoms for over 5 years, if you're over 50 years, if you're male, if you're a smoker, and if you're a little on the heavier side, or if you're Caucasian race, and if one of your family members had Barrett's in the past, that definitely should warrant further evaluation and discussion, and most likely with an upper endoscopy to make sure everything is all right there.
Working our way down through the GI tract, one of the other common conditions we see is peptic ulcer disease. And as you can see here in this diagram, peptic ulcer refers to a break in the gastrointestinal lining or mucosa of the stomach and duodenum. And this penetrates through the muscular layer of either one of the surfaces of the stomach or duodenum. The prevalence of peptic ulcer disease in the US is about 10% of the population, and it can be as high as 20% in those individuals that have H. pylori infection. H. pylori is an infection that you can contract by consuming food or water that is contaminated with this bacteria, and it can increase your risk of peptic ulcer disease. Another common cause of peptic ulcer is the use of NSAIDs, non-steroidal anti-inflammatories. As you know, these are things that we buy over the counter and that we reach out for kind of indiscriminately. That would include ibuprofen, Aleve, naproxen, Motrin, and even low-dose aspirin. These are all considered NSAIDs, and they can increase your risk for peptic ulcer disease. The symptoms are quite variable, and they can range from very mild to severe epigastric pain or burning. Bleeding ulcers can cause black or tarry stools over time, and you may see this if you're paying attention to that. And if you have a large volume bleed where there's a lot of blood that gets dumped into the stomach, usually people feel pretty sick and nauseous, and in that setting, you might have some vomiting of blood. Obviously, patients that are older, that are on medications that are blood thinners for cardiovascular conditions, for stroke prevention and so forth, will be more likely to have a large, life-threatening volume bleed.
All right, I have the pleasure to talk about bloating. And bloating and flatulence is a very common symptom we face. And again, most of it is luckily benign and normal, and it's just a little embarrassing. But luckily, it's not associated with serious illness. There are a couple of things you can do. It's like avoid gas-producing food, cabbage, legumes, onions, broccoli, wheat and potatoes can be very gas-producing. And we all produce around 500 to 1,500 ml of gas every day. So that's quite a amount of air we pass. And the smell actually comes only from a few things. And some are produced by the bacteria that are in our gut. Others can come from certain foods we eat, as I just outlined. For example, pork meat also can cause bad smelling gas. If there's no improvement with those about other mentions, or like if you take over-the-counter simethicone gas X, then there are some other things we can evaluate and see if there are like too many bacteria living in your guts. We can try to cut out certain foods that are prone to cause like distension of the guts. If it's getting worse and you have other symptoms, it could be a sign that your gut is blocked either by constipation or by a growth. So that would need further evaluation. And we have great nutritionists that kind of can go over with you what foods to avoid and what is better for your health. When it becomes to a point that you kind of have abdominal pain all the time, especially at night, if you're kind of distended and uncomfortable, if you're losing weight, if you have blood in your stool, if you got fever, vomiting, or your abdomen is really tender from the bloating, that obviously is a red flag, and that needs immediate evaluation, and you should talk to your primary doctor or to us about those symptoms.
The next topic we wanted to cover was diarrhea, because this is something that we very commonly see. And the causes for diarrhea are quite variable. And we'll go into some of these into a little bit more detail in the next few slides. But we wanted to mention there's so many things that can cause diarrhea. And these can range from celiac disease, food intolerance, whether to fructose or lactose later in life, infections with parasites, bacteria, viruses, which would usually lead to a short-lived type of diarrhea, problems with the pancreas or the gallbladder that Dr. Strobel will cover as well in the next few slides, inflammatory bowel disease such as Crohn's disease or ulcerative colitis, irritable bowel syndrome, cancer, particularly colon cancer, can be a cause for diarrhea. And then medications is a very common cause of diarrhea. There's many medications that can produce these symptoms, just like there's many others that can lead to constipation. I wanted to cover a little bit more about celiac disease because there's a lot in the press and out there about gluten sensitivity and celiac disease. So celiac disease is a sensitivity to gluten that leads to malabsorption and diarrhea. As you can see here in the picture on the right, the top panel shows what the normal small bowel will look like. And as you can see, those finger-like projections increase the surface area of the small bowel to allow you to maximize the absorption of nutrients, vitamins, and minerals that we ingest in our diet. That's what a normal gut looks like. In the case of celiac disease, as you can see here in the bottom panel, you lose those finger-like projections and there's a flattening of the mucosa. So you reduce your absorptive capacity quite a bit. And leads to some of the symptoms related to celiac disease, which I've outlined here, such as diarrhea, iron deficiency, anemia, other vitamin deficiencies, and some weight loss potentially. The prevalence of celiac disease is about 1 in 100 individuals in the US, and is higher in those with European descent. In order to have celiac disease, you need to have these mutations, HLA, DQ2, and DQA, which will predispose you to the development of the disease. And this is usually done with a blood test. So the initial diagnosis, we check for an antibody to something called TTG, which is a gluten part of allergen. And then we confirm it with endoscopy to obtain biopsies that would show this flattening of the mucosa and a specific inflammatory infiltrate that leads to that inflammation and destruction of the villi. In addition to the other clinical features I mentioned of nutritional deficiencies and so forth, celiac can manifest with joint aches, some dermatitis or rash that is very typical for the disease, and in the worst case scenario, the development of small bowel lymphoma, which is a type of cancer that can be deadly. The treatment for celiac disease is lifelong gluten avoidance, which includes products that are made of wheat, barley, or rye. This is easier said than done. It's quite difficult actually to be very successful at having a gluten-free diet. And here at Mayo, we work with a very good group of nutritionists that can help with menu planning and really educating patients as to how they can do this successfully. I have had patients with celiac disease that have told me that, you know, they even have their own toaster. Their family toasts their bread in one toaster and they have their separate toaster, because something as simple as that, putting their special gluten-free bread in another toaster can contaminate and lead to accidental ingestion of gluten. So it's quite difficult to do successfully, but we definitely have a good team of people that can help patients with making that transition if it needs to occur. There's also the other issue with patients who do not have celiac disease, but they have a gluten sensitivity, where every time they consume gluten, they feel bloated, they feel discomfort, and when they avoid this in their diet, they feel much better. And in those cases, we certainly, applaud them for doing the gluten-free diet, but it's not necessarily a diagnosis of celiac disease, so it doesn't require a lot of the monitoring on a yearly basis for vitamin deficiencies and so forth. Shifting gears to inflammatory bowel disease, this is a spectrum of autoimmune disorders that includes ulcerative colitis and Crohn's disease. Crohn's disease can affect you anywhere from the mouth to the anus, and ulcerative colitis only affects the colon. The causes, as we currently understand for IBD, is a combination of having a genetic predisposition and then some sort of environmental trigger that sets off the immune system to start attacking the body. Dietary issues have also been associated with inflammatory bowel disease, and we know that in the Western countries, with the type of diets that we consume, there's higher incidence for IBD. And so there's the component of diet there as well. The diagnosis of IBD is usually done with a combination of factors that includes endoscopy, radiographic findings, blood tests, pathology results. There's no one test that can say that you have IBD, but it's usually a combination of tests, and the selection of it will be determined by your physician based on your symptoms and physical exam findings. The symptoms can be quite diverse, and as you can see here, it can range from abdominal pain, diarrhea, fever, weight loss, and also some extraintestinal manifestations, which are common with inflammatory bowel disease. That includes eye inflammation, joint pain, joint swelling, oral ulcers on a regular basis, and some skin rashes and tender bumps and lumps that can be associated with a flare of inflammatory bowel disease. It's usually diagnosed early in life, so people in their 50 to 30-year range is where we see most of a new diagnosis of inflammatory bowel disease, but we know that it can occur throughout life, and there's a second peak in the fifth decade, 50 to 70-year-olds, we see a second peak with new IBD diagnosis. There's multiple treatment options for inflammatory bowel disease, and the goal is to induce remission and resolution of symptoms. And people can have very fulfilling, normal lives once their disease is under control. The treatments range from oral medications to intravenous infusions that we give in the hospital to self-injectable drugs, and in some cases, even surgery. There is no cure for the disease at the present time, but there's a lot of research and clinical trials that we participate on that we can offer to patients to try to get their disease in remission.
Yeah, changing to a different organ, the pancreas, which I like, but I feel bad for the pancreas because it's kind of ugly, it lives in the dark, and it has a really bad rep because it has either cancer or is inflamed, so people usually don't like it. But it's an important organ, and it helps us digest food and absorb food, so it has a central role. It makes juice that is like, I always call it dish soap, because it kind of dissolves the fat so we can absorb it. And as you might not know, but a lot of vitamins are actually dependent on fat, like vitamin D, for example, can only be absorbed if we are able to absorb fat. The pancreas also makes insulin and other hormones that help us control our blood sugars and control our digestive system. Its location is kind of right in the middle of us. It's in front of the spine, behind the stomach. So that's why it doesn't really have a classic location of pain or discomfort. If you ever, which probably you will never do, but if you ever touch it, it has a spongy consistency. It's about 6 to 10 inches long, and it's shaped like a fish, and also has names like a head, a body, and a tail of the pancreas. So next slide. So things that can go wrong with the pancreas, and which I'm interested in, is it can get inflamed. And the two common causes of pancreatitis in the United States are still gallstones, and the way the gallstones cause pancreatitis is they can block the tube that drains the juice out of the pancreas because it ends at the same area where the bile ends. And that basically makes a back look like a clogged kitchen sink. And basically then the pancreas starts digesting itself. And that's why it's so dangerous. This can be treated medically and also with an endoscopy where we go into the bile duct and can take the stones out. We can also treat the long-term consequences of an acute episode of pancreatitis when you have a big abscess there. We can train endoscopically now. In the old days that required surgery, so it's much more convenient nowadays. The other etiology is alcohol, though it's not completely clear what causes alcohol to cause pancreatitis. Not everybody who drinks gets pancreatitis. And then there are other causes. So if you have pancreatitis or had pancreatitis in the past, it's definitely worthwhile talking to us and kind of see how we can prevent further attacks. The other reason we see a lot of patients in our clinic are pancreatic cysts. So you might get a call from your doctor that you had a CT scan for a broken hip or a kidney stone, and then they found a cyst in the pancreas. So usually that's not a thing to get worried about and lose sleep over, but it's definitely worth to see an expert on that and get it further evaluated. There are very different types of cysts in the pancreas, and a small amount of them have the potential to turn into cancer. That's why it's important to see one of us and go over things with you, and we can order more tests to give you reassurance and keep an eye on those cysts. And then obviously the sad part of the pancreas is pancreatic cancer, which is still a very silent cancer and still a very bad prognosis in general. But again, the sooner it's detected, the better the outcomes. So if you have any symptoms in your family or anyone in the family had pancreatic cancer, or you have any risk factors for pancreatic cancer in form of chronic pancreatitis or other genetic mutations, please contact us, call your primary care provider. And there are now screening programs available for patients with high risk, like if 1 or 2 family members have pancreatic cancer, first degree, then you should definitely talk to us and we can get you on the surveillance program there. Next slide, please. Right next to the pancreas, and they're all kind of linked together, is the gallbladder. We kind of divide that field with the surgeons, so the surgeons are in charge of taking the gallbladder out. But we also see patients with gallbladder dysfunctions. Sometimes when patients are not able to undergo surgery because they're too old or too sick for surgery, we can treat that endoscopically now. Certain diseases of the gallbladder, put stents in there, drain it. With endoscopic ultrasound, we also can have a close look at the gallbladder. And stones can form in the gallbladder, travel down the bile duct, as you see on those images here. That can cause severe pain. That can also be treated endoscopically. And from the prior slides, you remember that can cause pancreatitis or a really bad infection of the bile duct. So that's something we can take care of, and we're all equipped with that here.
Thank you, Dr. Strobel. The last 2 topics we wanted to cover was rectal bleeding and colorectal cancer. As you can see here in this slide, there's many causes of rectal bleeding and many more that didn't make it to the slide, but it can be something as benign as having hemorrhoids or an anal fissure, which is a little tear or breakdown in the anal canal or outside the anus. You would see that usually with blood in the tissue paper when you wipe after having a bowel movement. But rectal bleeding can also be caused by a variety of things that can be a little bit more serious and dangerous. And that could include inflammatory bowel disease, some inflammation of the blood vessels, as vasculitis, ischemia, which is a lack of blood flow or, for a period of time to the colon that can lead to rectal bleeding. And very commonly, which we see here in Wisconsin quite often, is a diverticular bleed. So patients with these outpouchings in the colon can have an unheralded episode of bleeding. Usually tends to be painless, but needs to be evaluated and taken seriously. And then obviously the more concerning thing will be colorectal cancer. So colorectal cancer is one of the most commonly diagnosed cancers in the US and the leading cause of cancer death. Colorectal cancer usually starts as a polyp, a very little small growth in the colon. And at the earliest stage, or stage 1, there's cancer cells within that polyp. And then it can progress to a stage 4, where the cancer penetrates through the entire lining of the colon, and it goes to other organs like the liver or the lungs or the lymph nodes. The symptoms are quite variable. It can be quite silent until a later stage, but there can be also some warning signs earlier on that you should not ignore. That would include rectal bleeding, which is usually painless, a change in the caliber of the stools, described as a pencil-thin stools or a narrowing of the stools. You can also develop cramping or abdominal pain as the colon is contracting very vigorously to pass stool through an area that is partially blocked by a mass that is growing. Weakness and fatigue from anemia, chronic anemia that can ensue as a result of chronic blood loss with cancer, and then unintentional weight loss. I think in general, whether GI or other specialties, anytime that there is significant weight loss without trying really hard to diet and exercise, that should always prompt an evaluation with your primary care doctor, who can then sort of direct you into the right specialty for further evaluation. Risk factors for colon cancer include drinking alcohol and smoking. These are bad for just about anything, particularly drinking alcohol in excess. A family history of colon cancer would increase your risk of colon cancer, increasing age, and consuming a lot of grilled foods. The treatment for colon cancer varies depending on the stage, but it usually involves some sort of surgery plus chemotherapy and or radiation depending on the stage. And Dr. Strobel will go a little bit more into some other treatment options and endoscopic options that we have. In terms of prevention, obviously avoiding those things that are noxious, like drinking too much or having too much grilled foods and things that contain carcinogens, smoking. And then protective factors include having a healthy diet, reaching fruits and vegetables and fiber, and exercising.
Thanks, Dr. Batista. Yeah, so colorectal cancer treatment is like raising a child. It takes a village here, it takes a team, and we're lucky enough to kind of provide all that here and even at Rochester if we need further levels of care. So it usually consists about surgery. That's the best option when you can just cut it out, the cancer. We now also have like endoscopic treatments available, where in the old days you needed surgery. We can now do a lot of things endoscopically and save the big cut in your belly. That's the next thing, the gastroenterology. We can do endoscopy, we can place stents, we can take big polyps out. We also have better diagnostic images nowadays. Then oncology is the third column in this treatment, which means chemotherapy. And there are tons of studies and new treatments available now for colon cancer. So there's a lot to discover there. And then the fourth was radiation therapy, which is basically treatment to an area that's affected from the cancer. And as you see on the right side here, the earlier you find it, the better. If it's still localized, 5-year survival rate is 91%, so that's excellent. And even if it's like grown a little bit, it's still 72%. So what that means is the earlier you come, the earlier you hear the warning signs of your body, the better it is. I know it's sometimes you're afraid of the diagnosis and you don't want to see a doctor because you kind of know what's going on there, but I encourage you to come to us or to primary care doctor, because the earlier you catch it, the better the outcome is. Now, to summarize all what we talked about, I know it was a lot of topics that we covered in this short time, but it's great that you're here and that you're interested in it. That kind of shows that you're interested in your health and you're the best advocate for your own health. And together with our help and expertise, we'll do great things. So the 3 rules are basically never ignore signs of unintentional weight loss, bloating, rectal bleeding, difficulty swallowing, change in your bowel habits. Your body is usually pretty good in telling you when something is wrong, and the patient is usually pretty good knowing those symptoms when something is not right. Again, occasional constipation, diarrhea, heartburn, that's fine. You can do over-the-counter remedies and there are whole aisles of it. But if it persists for a longer time, if you need more medication, if the medication you got from the pharmacy stops working, that's usually a sign something is wrong, and that's time to see one of your doctors. Objective, accurate diagnosis is available, and there's an evolving field. It's getting better, more accurate, more precise. Instruments, technology is improving rapidly. So artificial intelligence is going to help us in the future to provide better care and offline care. So those are all things to look out for, and never hesitate to ask. If you're worried about something, WebMD is great, but the real MD is still better, I think. I think you're on mute, Dr. Molling.
You're muted, Dr. Molling.
It wouldn't come off. All right. Can you hear me now?
Yes.
All right. Well, sorry about that. Again, thanks for that wonderful program, Dr. Batista and Dr. Strobel. Trust your gut. We're going to move into question and answer time right now. And maybe I'll take one of the first questions that we received. Can you just briefly review the screening recommendations that are out there for colon screening? And then when should I be screened for esophageal cancer? What are your recommendations there?
Dr. Batista, you want to take up the colorectal cancer part, and I'll line out?
Sure. So in the last year, the screening recommendations changed from age 50 to start colonoscopy to age 45. So we should start screening at age 45. And these we should see being covered by insurance nationwide, since this is one of the USPSC recommendations. The screening can be done with colonoscopy. It can also, which is the gold standard and the better test for screening for colon cancer, but it can also be done with some stool testing for the right patients. These are patients who do not have a family history of colon cancer, who do not have a history of rectal bleeding, change in bowel habits, etc. Stool testing is not recommended for patients that have had polyps. Once you've been detected to have polyps, then that is no longer an appropriate screening test.
In regards to esophageal cancer, basically there are some risk factors, but there's not a clear screening like for the colonoscopy. So if you have Barrett's esophagus, and I mentioned that earlier, if you have a long-standing history of heartburn, if you're over 50, if you're male, if you used to smoke, if you have any difficulty swallowing, or if anyone in your family had Barrett's esophagus, then that definitely requires screening in form of an upper endoscopy.
On that same topic, one of the questions was, can I heal my esophagitis? Can you take medicine to take care of that?
Absolutely. There are a bunch of medications. The most used or the strongest one are those what we call proton pump inhibitors, or short form PPI. They suppress the acid production in the stomach, which then decreases the acid exposure in your food pipe and then lets it heal. And again, there are also surgeries available. For example, if you have like a hiatal hernia, which is when part of the stomach flips into the chest, that can be treated surgically, and then you don't even have to take any medications anymore. So you can definitely heal your esophagitis.
Thank you. I know you touched upon this, Dr. Batista, but can I cure my inflammatory bowel disorder? I know you touched upon it, but there's a number of questions that have been raised around that. And if you could just touch upon that quickly again for us, that'd be great.
Sure. So we can heal the bowel with the right combination of therapies. There's no cure for it in the true sense of what a cure is, which is you treat it, you get rid of it, it never comes back. The treatment for inflammatory bowel disease is lifelong, and once you stop it, it's likely that the disease will come back. So it can be treated successfully and lead to a normal life, but there's no cure for it that we know of as of yet.
All right, well, thank you. Going back to Dr. Strobel. Dr. Strobel, is it okay if I were to take over-the-counter anti-reflux medications, or should I talk to my doctor first about that?
It is okay to take it for a short period of time, or if you have heartburn now and then. If you have if you require the anti-acid medication more than 2 or 3 times a week, or even on a daily basis, and you need it twice a day or take 2 of them, then that's definitely something to talk to your doctor about.
Thank you. Are there diets that you two could recommend that would help my digestive system more than another, or your recommendations surrounding what is best for me?
I think it depends on the condition. I mean, there's certain dietary modifications that are recommended for patients that have reflux, like having small frequent meals as opposed to a large meal, avoiding carbonated beverages, etc. There is patients with irritable bowel syndrome that can do really well with a FODMAP diet. And in terms of inflammatory bowel disease, there are certainly certain diets that have been shown to have some anti-inflammatory effects, like the specific carbohydrate diet and the Mediterranean diet, that can be quite beneficial. In and of itself, it wouldn't be a treatment for inflammatory bowel disease, but it's certainly a nice adjunct that we encourage patients to follow if they feel so inclined. So it depends on the condition, but yes, there's certain dietary manipulations that can be done to help improve your gut health.
So a good diet you could recommend would be Mediterranean, or just eating the food pyramid.
Right. I mean, in general, the more that we do sort of like natural foods that are prepared without a lot of preservatives and additives and things like that, the better off we are.
Perfect. Can you talk to me about the sugar supplements, and why does that cause me to have so much DI distress?
Yeah, so those are sugars that are not absorbed. And that's why they're considered artificial sweeteners. So they don't go into our bloodstream. But what happens is that the sugars are like the dairy sugar, the lactose, consist of different molecules, and the molecules have to be split in order to be absorbed. So our body cannot split those artificial sweetener sugars. So what happens then is that they travel all the way down into the large intestine where all the bacteria live. And of course, they're gonna have a blast getting all that sugar and basically break that sugar down and ferment that and cause bloating in some patients and diarrhea and really bad cramps. So if you ever wonder what happens, just YouTube the sugar-free gummy bears and you'll gonna get an idea on what's happening.
Thank you for sharing that. Is there a number of bowel movements that is normal for an individual per week?
So that's a great question, and a lot of patients are worried about that. There was actually a study that looked the variation on bowel movements, and it confirmed the known saying that 3 times per day or 3 times per week is completely normal. So anywhere between that is fine. And, you know, as long as you don't have any symptoms, pain, weight loss, rectal bleeding, even going once a week can be okay. It's very individual about the bowel movements.
Thank you. How about dietary prior to going to bed? Do you have recommendations around that?
Yeah, in regards to, you should avoid late meals, like 2 to 3 hours before bedtime. It's probably good not to snack anymore. I mean, it's very comfortable sitting in front of the TV eating ice cream, but try to avoid that, and also try to avoid carbonated beverages, because that's all gonna blow up your stomach, make it full. Then when you lay down, it's pure physics that increases the risk of heartburn and long-term damage from heartburn.
On that same topic, is fasting good? Should I go for periods and fast?
I think there's a lot of information emerging on that, and for the purposes of weight loss, may be beneficial to do the intermittent fasting. I think the jury's still out as far as like how it impacts gut health in general, but certainly for weight loss, it has been shown to be quite successful to have either a 12 or 16-hour fast.
We're receiving also, thank you, Dr. Batista. We're receiving a number of questions about probiotics. I know this is a broad spectrum topic, but can you just briefly touch upon probiotics and your thoughts on them?
Yeah, I think probiotics and in general, our knowledge and understanding of the microbiome, the composition of bacteria in our gut, is emerging. I think we have learned a lot, but we're still at our infancy in understanding how to manipulate that. So in general, I would say there's very few conditions in which it has been shown to be beneficial in a truly kind of like scientific way, where you're comparing a given probiotic to a placebo, to a fake medication made to look and taste and smell like the actual medication. So I think probably in the next few decades, we will learn more and be able to more specifically manipulate it. But I think we're still very much in the dark ages with knowing that it's a multi-billion-dollar industry. And usually when I see patients in clinic for a variety of conditions, I tell them, and they come already taking a probiotic, I say, do you feel better on it? If you do, and you stop it, do you feel worse? Then by all means, feel free to use it. But if you don't notice any difference, which is what I hear most of the time from the patients, oh yeah, I'm taking this probiotic and that one, do you feel better? No. Stop it and see what happens. Do you feel worse? Because if not, it's probably a waste of money and resources to use that. So I think an exciting topic that in the next few decades, we will learn more and more about. There's certainly a ton of research being done in the microbiome to understand how to use probiotics and how to manipulate our system, but we're not there yet. So in general, I don't recommend it except for a very select couple of diseases, basically, in which it has been shown to have benefit.
Perfect. We're going to wrap up with one more question here. Can you this is a very broad topic, constipation. When to be worried, when not to be worried. Thoughts on constipation?
Yeah, so every time something changes rapidly, for example, if you had irregular bowel movements and then by a sudden you develop constipation, if you have associated pain with that, if you're over 50 years old, if you have rectal bleeding with it, and if you feel uncomfortable, then constipation is not normal anymore. And then you should have it evaluated. If you don't go to the bathroom for 1 or 2 days and over-the-counter stuff helps, then that's okay. But again, if it continues to be a problem, and if you don't feel comfortable with it, then it's definitely worthwhile asking your primary care provider or one of us.
The other thing I would like to add about constipation is particularly in women as we get older and have gone through pregnancies and childbearing and this and that, there can be pelvic floor dysfunction, a weakness and a dysfunction in the pelvic floor muscles. And these can be significantly improved with pelvic floor rehab therapy. There's testing to be done for that to confirm that that's what's going on. So it's not just a question of medications and using a whole bunch of over-the-counter or prescription things, but just understand that as we get older, that can become a problem, particularly in women. And going to a place where there's a good, robust pelvic floor program, it's important and can be quite helpful. And we certainly have that here. So I would encourage people to seek care in that setting just for their own quality of life and to improve things as we get older.
Well, thank you very much. We can go to the next slide here, please. Again, we want to thank our wonderful speakers today, Dr. Strobel and Dr. Batista, for their expertise in the review of the gut and the whole gastrointestinal tract. So thank you very much, and thank you for answering our questions. We can move to the next slide, please. I also want to thank our guests for joining us today. We also want to review that we have an upcoming program, Solve, Don't Settle, Treatment for Urinary Incontinence. This will be held August 24th at 4 p.m. via Zoom. Once again, please, next slide. And if you have further questions that you would like to ask or to make appointments, feel free to contact us via the methods below, via phone. We have your Mayo Clinic app, patient online service, or go to mayoclinicthehealthsystem.org or follow us on social media. So with that, that will conclude our program for today. And again, I want to thank everyone for joining us. Have a wonderful day.